Picture this. You're 74 years old. You wake up most mornings feeling like yourself. You sleep reasonably well. Your energy holds up through the day, and you're still doing the things that make life feel like your life. Gardening, walking the dog, Sunday dinners with the grandkids. Then you go in for your annual physical. Nothing dramatic, just the usual check-in. Your doctor glances at your chart, taps a few keys, and says the sentence that starts more medical journeys than almost any other sentence in modern healthcare. Let's run a few tests, just to be safe. 6 weeks later, you're not in your garden. You're sitting in a surgeon's waiting room, filling out intake forms, because one of those just-to-be-safe tests found something. And that something set off a chain of events your 74-year-old body was never quite built to absorb. I want to be very clear before we go any further. This is not a rare story. It's a pattern that repeats itself in exam rooms across this country every single day, documented quietly in journals most people never read. My name is Dr. James Revealio, and this channel exists for one reason: to take what the research actually says about aging and health and hand it to you in language you can use at your next appointment. Not fear, not hype, just the evidence, translated. Here is a truth that very few doctors will say out loud in a 15-minute appointment. After the age of 70, several of the most common, most routine, most of course you should get this medical tests can cause more harm than good. Not because medicine is broken, not because your doctor doesn't care, but because the math, the actual risk versus benefit math, shifts dramatically as we age, and almost nobody is doing that math out loud in the room with you. Today I'm walking you through 5 specific checkups I would personally sit down and reconsider after 70. I'll explain exactly why the math changes, I'll walk you through what the research shows happens to real patients, and at the very end, I'm going to hand you a 5-question framework that will change the entire dynamic of your next doctor's visit. Stay with me. Number 3 is the one that stops people cold when they hear it for the first time, and number 5 is the one almost nobody has ever heard of until it's too late to matter. I also want to say this plainly, right at the start. Nothing in this video is about avoiding your doctor, skipping your checkups altogether, or treating medicine with suspicion. It's the opposite. This is about walking into that exam room as an informed partner in your own care instead of a passive recipient of it. Before we dive in, I'd genuinely love to know where you're watching from today. Drop your city or country in the comments. Alright, let's get into it. Before we touch the 5 checkups themselves, I need to hand you one concept first, because without it, nothing else in this video will fully land. I call it the longevity lens, and once you see healthcare through it, you can't unsee it. Here's the idea. When you're 50 years old, screening medicine is one of the great success stories of modern healthcare. You catch a problem early, you treat it while it's small and manageable, and in exchange you potentially buy yourself 30 more years of healthy living. The math works beautifully in your favor. But something shifts after 70, 3 things, specifically. Asterisk, asterisk. First asterisk, asterisk. A huge number of conditions caught through routine screening in older adults were never actually going to hurt you. They grow slowly, they cause no symptoms. You were far more likely to live out your natural lifespan without them ever causing a single problem. But medicine doesn't really have a leave it alone and keep an eye on it button. Once something shows up on a report, what it has, almost by default, is a treat it button. Asterisk, asterisk. Second asterisk, asterisk. Your body's tolerance for intervention changes with age, more than most people realize. The exact same surgery that a 55-year-old bounces back from in 2 weeks can mean 2 months of recovery, complications, or a permanent loss of independence in a 78-year-old. The procedure hasn't changed. The body receiving it has. Asterisk, asterisk. Third asterisk, asterisk. And this is the one I want you to really sit with. There is something in medicine called the cascade effect. One test finds a small, ambiguous abnormality. That triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And just like that, a person who walked in feeling completely healthy is now navigating a medical crisis that started with a test they never actually needed. There's a phrase researchers use for this: competing risks. At any given age, there are multiple things that could shorten your life or reduce your quality of life, and treating one aggressively only makes sense if it's actually the risk most likely to reach you first. For a healthy, active 80-year-old, a slow-growing finding on a scan may never even make it onto that list. A fall, an infection, or a medication side effect might realistically pose a far greater threat. This isn't a criticism of any individual doctor. Most physicians are working inside 15-minute visit windows, following guidelines often written with a general younger population in mind. The longevity lens isn't about blaming the system, it's about giving you the missing piece of context that the system often doesn't have time to hand you itself. And quickly, if you haven't already, tell me your first name and where you're tuning in from down in the comments. #Checkup1. Routine colonoscopy after age 75. Let me tell you about a woman I'll call Eleanor, 77 years old, a retired school teacher living outside a small Midwest town. She'd had 2 colonoscopies in her life, both completely clean, no polyps, no family history, no symptoms of any kind. Eleanor had recently switched primary care doctors, and her new physician looked at the chart, saw it had been a while, and said she was due. Eleanor had a nagging feeling she probably didn't need it, but didn't want to seem difficult, so she scheduled it anyway. The prep, the liquid you drink the night before to clear the bowel, hit her kidneys hard. By the next morning she was disoriented, dizzy, and could barely stand. Her son rushed her to the emergency room before she ever made it to the procedure. She was severely dehydrated, her electrolytes had dropped to dangerous levels, and her heart rhythm was closely monitored. She spent 4 days in the hospital. She never even had the colonoscopy, and she never needed it in the first place. This isn't just one unlucky story. The United States Preventive Services Task Force, the independent panel that sets national screening guidelines, officially recommends against routine colonoscopy screening for average-risk adults over 75. Past that age, with no symptoms, no relevant family history, and a clean screening history, the risks of the procedure begin to outweigh the potential benefit. Bowel perforation. An actual tear in the colon wall occurs in roughly 1 out of every 500 colonoscopies. In a younger adult, that's a serious but manageable complication. In a 77-year-old, it can mean emergency surgery, a colostomy, and weeks of hospitalization. Meanwhile, the colon cancers most likely to be discovered incidentally in an asymptomatic older adult tend to be the slow-growing kind, often slow enough that they would statistically never have caused a problem within that person's remaining lifetime. There's also the bowel prep itself, which rarely gets discussed openly. For a healthy 50-year-old, an evening of laxative solution is a manageable inconvenience. For a frail or even moderately healthy 78-year-old, that same prep places real strain on the kidneys and can trigger dangerous electrolyte drops, exactly what put Eleanor in the hospital before the test even started. So what should you do instead? If you're in this age range with a clean screening history and no symptoms, ask your doctor about a non-invasive stool-based test, a FIB test, or a stool DNA test. These can flag real warning signs without procedural risk. And to be clear, if you have symptoms, blood in your stool, unexplained weight loss, or a real change in bowel habits, that changes everything. That warrants a direct conversation with your doctor, without delay. #Checkup2. Aggressive cancer screening in low-risk, asymptomatic adults. I want to be precise here, because this deserves real nuance, not a blanket statement. I am not telling you to skip cancer screening. It has saved millions of lives, and for the right person at the right time, it can save yours too. What I am saying is this: after roughly 75, aggressive cancer screening in average risk, symptom-free individuals runs into a documented problem called overdiagnosis, which has a habit of leading directly into overtreatment. Overdiagnosis means this: modern imaging is so sensitive it can now detect cancers that are, biologically speaking, barely doing anything. Tiny, extremely slow-growing tumors that, if left alone, would never spread, never cause a symptom, and never shorten a person's life. A person in that situation dies asterisk, with asterisk the cancer, not asterisk from asterisk it. But the moment a report contains the word malignancy, the clinical process activates almost automatically. Biopsies get scheduled, specialists get involved, treatment moves forward. often regardless of whether that cancer ever posed a real threat. Consider a case like that of a man I'll call Walter, a 79-year-old retired mechanic, still out fishing most weekends. A routine PSA test came back mildly elevated. A biopsy confirmed a low-grade, extremely slow-moving prostate cancer. His urologist recommended radiation. Walter trusted the recommendation and went through with treatment. Within a year, he was dealing with chronic fatigue and urinary complications that noticeably reduced his quality of life. Stories like Walter's show up again and again in the medical literature. Men who, in hindsight, wish someone had told them their cancer was the type they were overwhelmingly likely to live alongside not die from. Research published in major medical journals has found that a meaningful share of cancers detected through routine mammography in women over 70 were, in retrospect, clinically insignificant, meaning treatment provided no measurable survival benefit, only the side effects. So what should you actually do? Have a direct conversation with your doctor about your personal risk profile. If you carry a strong family history, known genetic markers, or actual symptoms, screening remains important. But if you're average risk and symptom-free, ask this exact question. If we find something on this test, what are the realistic treatment options for someone my age, and what would we most likely recommend? That question tends to completely reshape the conversation. If this is landing for you, drop a 2 inches in the comments. Checkup 3. Routine cardiac stress testing without symptoms. This one tends to surprise people, mostly because it sounds so responsible on the surface. Your doctor says, "You're 72, let's just make sure your heart's doing okay." And you hop on a treadmill, or you're given a medication that temporarily stresses your heart while it's monitored. It sounds harmless. It sounds thorough. Here's the complication nobody mentions. Cardiac stress tests performed on people with zero symptoms carry false positive rates that can climb to 40% or higher in certain populations. That means, in a striking number of cases, the test flags something abnormal when the heart is in reality functioning just fine. But medicine can't simply shrug off an abnormal result. A flagged finding tends to trigger the next step almost automatically, a cardiac catheterization, threading a thin tube through a blood vessel, typically the wrist or groin, directly into the heart. This is not a minor procedure. It carries real risk of bleeding, vessel damage, abnormal heart rhythms, and in rare cases, it can even trigger the very heart attack or stroke it was meant to help prevent. And here's where it gets genuinely counterintuitive. If the catheterization uncovers a partial blockage, extremely common in adults over 70, the vast majority of whom have no symptoms whatsoever, the next step is often a cardiac stent. Multiple landmark clinical trials, including the widely cited ischemia trial, examined exactly this scenario in patients with stable coronary artery disease. The finding was striking. Stenting did not reduce heart attacks or extend life expectancy compared with medication and lifestyle management alone. The stent in this population performed no better than medication, but it came with its own procedural risks, followed by a lifetime commitment to blood thinners, which carry their own bleeding complications. So walk through the full sequence. You started out feeling completely fine. A routine test triggered a false alarm. The false alarm led to a catheterization. The catheterization found something common but not dangerous. That led to a stent. The stent led to lifelong blood thinners and ongoing monitoring. And at the end of that road, you are, statistically speaking, no better off than someone who simply managed their risk factors with medication and a 30-minute daily walk. I think of a man I'll call Harold, 73, who mentioned to his doctor almost in passing that he wondered if he should get checked just in case. He had no symptoms, he mowed his own lawn, walked 2 miles most mornings. The stress test came back equivocal. That ambiguity alone was enough to trigger a referral to catheterization, which revealed a moderate blockage that had almost certainly been sitting there, stable for years. He ended up with a stent he likely didn't need, on top of a blood thinner regimen he'll now be on indefinitely. No dramatic ending, no heart attack, no crisis, and that's exactly the point. He simply traded a symptom-free life for a more medicated, more monitored one, without clear evidence the trade extended his life at all. What should you do instead? If you have no chest pain, no unexplained shortness of breath, and no dizziness during activity, routine stress testing is essentially searching for problems in a population where abnormal-looking but harmless findings are common and intervention doesn't reliably help. A far better conversation is about optimizing the risk factors that actually move the needle: blood pressure, cholesterol, blood sugar, activity level, and sleep. Checkup 4. Routine bone density scanning with automatic medication. This next one tends to make people uncomfortable, and I understand why. Osteoporosis is real, and falls in older adults can be genuinely devastating. So let me be careful with how I frame this. I am not questioning whether bone loss with age is real. I am questioning the automatic pipeline that often follows a bone density scan result in patients over 75. Here's how it typically unfolds. A DEXA scan detects low bone density. The doctor prescribes a bisphosphonate, medications like alendronate or resdronate. The patient takes them for years, assuming they're fully protected. But long-term bisphosphonate use has been associated with a rare but serious condition called an atypical femoral fracture, a spontaneous stress fracture in the thigh bone, ironically the exact bone the medication was meant to protect. These medications have also been linked to osteonecrosis of the jaw, a painful, notoriously difficult to treat form of jawbone deterioration. Meanwhile, the single most effective intervention for preventing fractures in older adults isn't a medication at all, it's fall prevention. Structured balance training, Tai Chi in particular, has been shown in multiple studies to reduce fall risk by nearly half, combined with removing tripping hazards at home, installing grab bars, reviewing medications for dizziness-causing side effects, getting regular vision checks, and ensuring adequate protein and vitamin D intake. These interventions reduce fracture risk more meaningfully than most medications, with essentially none of the downside. To be fair, medication is absolutely appropriate for some patients, those who've already had a fracture, those with very low bone density scores, those carrying specific risk factors, but a routine scan leading automatically to years of medication for an active 74-year-old who has never broken a bone and is otherwise healthy? That's a conversation worth having thoroughly, not a foregone conclusion to accept quietly. A fall usually isn't a random accident. It's the end result of several small, fixable factors stacking up at once: a slightly loose rug, a blood pressure medication that causes brief dizziness on standing, dim lighting on the stairs, weakening leg strength, and glasses overdue for a new prescription. Address even 2 or 3 of those factors, and the odds of a fall, and therefore a fracture, drop meaningfully, often more than any single medication would achieve on its own. Here's what to ask your doctor. Before we discuss medication, can we review my actual fall risk factors? And what is the real fracture risk reduction from this medication compared with a structured fall prevention program? If you've made it this far, drop a 4 inches in the comments. Checkup 5. Asymptomatic carotid artery screening. This is the one almost nobody talks about, and based on what the research shows, it may be the most quietly consequential item on this entire list. A carotid artery ultrasound checks the large blood vessels in your neck that supply blood to the brain. The logic sounds airtight on the surface. If we find a significant blockage, we can surgically clear it and reduce your stroke risk. The reality is far more complicated, and for people without symptoms, far riskier than it appears. The surgical procedure used to correct a carotid blockage, called a carotid endarterectomy, carries roughly a 2 to 3% risk of causing a stroke during or immediately after the procedure. In older adults, and especially those with other underlying health conditions, that risk climbs higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults with no symptoms, no mini-strokes, no vision loss, no neurological warning signs of any kind. Their formal analysis concluded that in people without symptoms, the risk of surgical harm outweighs the potential benefit. Here's why. A large number of people over 70 carry some degree of narrowing in their carotid arteries, narrowing that has often been present, stable, and completely silent for years. When you screen for it routinely, you find it, and once it's found, a well-meaning specialist often recommends fixing it. But the surgery meant to fix a blockage that was never causing symptoms can, in some cases, dislodge a small piece of plaque that travels directly to the brain, the exact outcome the surgery was meant to prevent. The pattern in the literature is consistent. People walk into a routine screening appointment feeling perfectly well and leave on an entirely different trajectory, not because of the blockage that was found, but because of the intervention that followed it. There's an important distinction worth spelling out. Screening for stroke risk factors is not the same as screening the carotid artery itself. Checking your blood pressure, your cholesterol panel, and your blood sugar at a routine visit is genuinely valuable, low risk, and something I'd encourage every time. It's the imaging of the artery itself, done routinely with no symptoms driving the request, that the evidence pushes back against. So what should you do instead? If you have no symptoms of stroke or a transient ischemic attack, no sudden vision changes, no facial drooping, no arm or leg weakness, no sudden severe headache, routine carotid ultrasound is generally not recommended for you. The far better investment is controlling the modifiable risk factors that actually drive stroke risk: high blood pressure, blood sugar management, smoking cessation, managing atrial fibrillation if present, and staying physically active. And if you do experience any neurological symptoms, even brief ones that resolved on their own, seek evaluation immediately. #, a quick bonus, the full body scan trend. Before we get to the 5-question protocol, I want to mention one more trend, because several of you have asked me about it directly: the elective, pay out of pocket, full body MRI or CT scan. These are marketed heavily with the promise of peace of mind and catching anything early, but full body scans in people without symptoms run into the exact same overdiagnosis problem we discussed with cancer screening, just amplified across the entire body at once. These scans routinely turn up incidental-omas, small ambiguous findings in the kidneys, thyroid, adrenal glands, or elsewhere that are, in the overwhelming majority of cases, completely harmless. But once they appear on a report, they tend to trigger the same cascade we've talked about all video: follow-up scans, specialist visits, sometimes biopsies, all chasing something that was very likely never going to matter. There's no major medical society that currently recommends full-body scanning for asymptomatic adults at any age. If something is bothering you specifically, a real persistent symptom that deserves targeted investigation. But scanning everything, all at once, with no symptom to guide the search, tends to generate anxiety and unnecessary procedures far more reliably than it generates useful answers. #, the 5-question protocol. I promised you something practical, so here it is. Every single time your doctor recommends a screening test, especially if you're over 70 and feeling well, have these 5 questions ready, write them down, save them in your phone, bring them to every appointment. ***. Question 1. What is the false positive rate of this test in people my age? ***. This tells you how likely the test is to trigger an unnecessary chain of follow-up procedures, even when nothing is actually wrong.